So let's get going. Let's be sensitive of everyone's time. We're going to take about 45 minutes this evening. I want to thank everybody for joining us and for giving us some of your time today. We wanted to hold this call to review some information regarding the iFuse Bedrock Granite technology with a focus on the CMS new technology add-on payment for spinal fusion cases that use Granite. We thought it was timely for us to present this to you now so that you can evaluate it for your health systems and your practices. We encourage you to type any questions that you have in the chat feature of the Zoom, and we will address them at the end of the discussion, or we'll be following up with you directly. So we are so lucky to be joined this evening by Dr. Isador Lieberman, an orthopedic spine surgeon who I'm sure is well known to all on this call. Dr. Lieberman specializes in the surgical treatment of spinal disorders. His clinical interests include adolescent and adult scoliosis, deformity reconstruction, spinal tumors, minimally invasive, robotic, endoscopic spinal surgery, treatment of vertebral compression fractures, cervical and lumbar degenerative disorders, and trauma. Dr. Lieberman established the Uganda Charitable Spine Surgery Mission, which provides services to the less fortunate in Uganda who are afflicted with spinal ailments, including tuberculosis and scoliosis. And after an intro like that, I could be none other than the other much humbled co-host for tonight. I'm Jeff Zigler, and I serve as SI Bone's VP of Reimbursement. So it's a pleasure to be with you all, and thanks again, Dr. Lieberman.
Thank you for the introduction, Jeff. I appreciate all that.
You got it. So just brief agenda, then I want to let you talk. So tonight we'll review a few of your cases that use Granite, talk about the features of Bedrock Granite that you now view potentially as a benefit to your patients, as well as discuss some of the reimbursement related to those cases and present at a high level what NTAP or add-on payment would be appropriate for them. So we'll take a look at examples of NTAP at work, you know, what those on the call and the hospitals represented here may expect in terms of the add-on payment, along with the usual reimbursement for the case. So following that, we would be glad to take any of your questions, as I mentioned, so just type them into the chat throughout. So with that, Dr. Lieberman, I'll be happy to run your slides.
Well, good evening, everybody, and welcome, and thank you for joining us, and thank you for the interest. And Jeff, again, thank you for that introduction. I want to start with one of my typical cases. This is a 74-year young male. He's an active rancher. He had a 3-year history of substantial mechanical back pain and a more recent history of claudication symptoms. That's the numbness, tingling, and weakness in his legs when he tries to walk. He did have a previous traumatic L2 compression fracture, and if you look at the x-rays, you can see in the middle there, there's one vertebral body that doesn't look square. It's triangular or wedged down. That's gone on to heal and fuse itself. He has had 2 previous surgeries at the L4-5 and the L5-S1 level. And if you look at the x-rays there, again, you can see that those levels have collapsed, they've tilted off. And on exam, he was standing stooped forward, and neurologically, he had weakness of his right leg in the L5, the 5th nerve root region, with the muscles that affect the hip and the muscles that affect the ankle. So this was an individual who is trying to be active, limited by his back, by virtue of the posture, by virtue of the number of levels. I felt that I had to stabilize him and create a foundation from which to build on. One of the things that I've realized over the years is that much like skyscraper construction, you can't hold something up unless you have a solid foundation. So Jeff, the next slide, please. So this is what I ended up doing for him. I did decompress him and instrument him. This was a combined anterior procedure, meaning from in front and then posterior instrumentation. And you can see I've got screws in to L3, L4, L5, into S1, as well as the S2 iliac screws, where I used the Granite device to achieve fixation into the pelvis itself. Now, remember I said at the beginning that the L2 compression fracture to L3 had fused solidly, so I didn't have to go up higher than that, but I needed a good enough foundation to hold him up. So this is just one example of the use of the Granite device that gives us that foundation to hold the patient up. So this is what the Bedrock Granite device is. It's a long fixation and fusion device with a polyaxial head, meaning that the tulip on the end of it, that's the green end there, can toggle back and forth, and you've got the attachment to the rod, and you can see there's some very unique features in the design of this device. Next slide. So it's comprised of the three components, which is that tulip head. You've got the shank, which is anonymous or synonymous to a screw down the middle. And then you've got the sleeve that's designed for the biologic fixation. So what you are getting is a long, strong hold into it to create that foundation. Next slide. If you look at the sizes here, we've got the major and the minor diameter of the Bedrock or the Bedrock Granite implant, and you can compare that to the standard pedicle screws. So you can see that we're bigger, and the fixation in the bone is all about the implant bone surface area. So you can see with the various design features, there's a much more substantial interface between the bone itself and the screw compared to the standard pedicle screws that we use for pelvic fixation. Next slide. One of the areas where we've had issues with a lot of the pelvic fixation, and you can see that on the left X-ray there with the red circle, the head of the long screws can sometimes snap off. So we've designed the head for its maximum thickness, or the neck of the screw for its maximum thickness, so that we won't develop those breaks in the screws at that end. And then the ball, which the polyaxial tulip sits on, locks into that. Next slide. Now we're looking at the problem that we see with a lot of the standard screws. Because they're a solid shank, they can loosen over time, as you can see on that left X-ray again in that red circle. So the Granite device is designed, and by virtue of its 3D printing, we can create this lattice structure that mimics the morphology and architecture of the native bone, of the cancellous bone. So the bone cells think, this looks like bone, it feels like bone, and they actually stick to it. And that's what gives us some of the biologic lock with the interdigitation of bone into it. And we call this the IntelliHarvest lattice surface. Next slide. Along with that, we've got openings or fenestrations in the side that are designed like knife cutting edges, essentially. And what they do is, as you screw in the implant, it drives the bone from the medullary canal, from the cancellous bone of the iliac wing, into the device itself. So again, it's giving you that biologic fixation. And you've got different sizes along the length of it, so you have different geometries for that bone ingrowth to grow through it. Next slide. And then we've got the set screw and the tulip head itself. The set screw is specifically designed with what we call a negative rake thread. So as you are tightening that down onto the rod, it prevents the tulips from splaying apart because of the angle of the undersurface of that set screw. So it's a very unique design, and you can tighten it right down to about 115 inch-pounds, which will then hold the rod, engage the rod, and prevent some of the things that you can see on the left there, where set screws have disengaged from the tulip, and the rod then just becomes a free-floating piston inside the tulip head itself. Next slide. The way the OmniCapture tulip works, we can use it with multiple different rod diameters, 5.5 millimeter or 6 millimeter, and it provides a very easy integration with the C-Spine Mariner system that provides both those size rods. And you also have the favored angle of the tulip. So you can see by virtue of the shape of the bottom end of that tulip, it can rotate 40 degrees in any direction to give you a favored angle to make seating the rod into it much more convenient. Next slide. One of the final features is the drive tip design that we've got in it. Because it's got a standard screw inside the bone ingrowth sheath, we can add the tap features or the cutting edges there so that you can get really good fixation. And as it advances, it keeps cutting into bone and creating the channel all the way down. The device can fit some of the minimally invasive guide wires that we use, so this can even be done percutaneously, and it's got a double lead thread on it, so it helps it advance a lot quicker than just a standard single lead screw. Next slide. So this is the way we would typically implant it. We gauge our starting point, which is typically on the posterior portion of the sacrum between the first and second sacral foramina. That's where the nerves come out. And you can see the green dot on the far left that says starting point. We line up our X-ray, and the green dot is in the area of the film that we call the teardrop. Then we use a probe to probe down through the bone. And when I'm describing this to my fellows and residents, I'm telling them, it feels like you're pushing through a Rice Krispie square. You feel for the bone throughout, so you know that you're within the tables. Once you have the trajectory done with the pilot hole prep device, you then tap it, and particularly across the sacroiliac joint, because that bone can be very dense bone just at that level. And then you implant the screw all the way down. You have your other screws in place. You drop your rod into the construct, you do your correction, and then you can lock things in place. And again, because of the 40-degree angled favored head on there, we can really make it easier to drop the rod in. So it makes the surgery much more convenient than with some of the fixed head devices or some of the devices that don't have that full excursion. Next slide. So here's just the summary slide looking at all the various features with the OmniCapture tulip and the set screw, the larger neck, so you don't have the breaks of the screw at that end. You've got the IntelliHarvest cutting flutes, you've got the microporous lattice, you've got the fenestrations, and then you've got the easy drive tip. Next slide. So this is a second case, and this is a 73-year young male. Again, very similar history and story, 2-year history of mechanical back pain and a much more recent history of the stenotic claudication symptoms. He also had issues with his neck and presented back to me before I fixed his lower back with hand weakness and difficulty walking. So I had to fix his neck first. And you'll notice on the post-op x-rays that he had a neck operation, and then I did the lower spine operation. So we can go to the next slide, please. And again, this was a combined procedure going from in front first to realign the anatomy to stabilize him, then from behind to place the screws in. And you can see here that I've used stacked or 2 Granite devices on each side. In this case, in contrast to the first case, I'm achieving the fixation as well as the SI joint fusion. The fusion is by virtue of the fact that I've got 2 points of fixation across the sacroiliac joint, and with the bone ingrowth and ongrowth into the Granite devices, it gives us a lock of that sacroiliac joint so he doesn't run into any long-term issues with sacroiliac joint pain. So the first case was just a single Granite device on each side to achieve the fixation for our foundation. The second case here is the stacked sacroiliac S2AI or sacroiliac joint screws to achieve the fixation as well as the SI joint fusion. Next slide. So this brings me up to Jeff, and take it away.
Yeah, let me take it from here. Thanks so much for that, Dr. Lieberman. And thanks for the pretty pictures too. I know it's critical to my understanding, at least, of all that's going on here. So thanks for that. And let me just remind everyone, please feel free. We encourage you to use that chat feature. If you have questions, fire away during this portion upcoming, as well as if you had any questions for Dr. Lieberman as well. So I wanted to have a little fun. Fun in my world in reimbursement, that is, and I wanted to talk about Dr. Lieberman's two case examples he gave to us and put coding solutions to them for the physician and the facility. So in Dr. Lieberman's first case, the bilateral pelvic fixation, the typical lumbar or thoracolumbar spine fusion coding would apply, and they're not on this particular screen, not pictured here. In addition, if reported as that pelvic fixation with no fusion, then case one would also use the add-on CPT code 22848 that's on the screen to describe the work in the pelvis. So I'm going to try and slow down and go through some of the coding and billing rules for this coding as we understand it in a few more minutes. But for now, I just wanted to fly over what we feel the solution might be for this case. And so in case one, pelvic fixation only, the surgeon would report 22848, and Medicare unadjusted rate would pay that at $367 per case to the physician. Some payers may allow reporting of that code 2 times. That's great, but we feel that would be the exception. On the hospital's payment, the same DRG would apply to the case as typically would for a spinal fusion for curvature diagnoses, for instance. And that same DRG would apply in this case, even with the inclusion of the SI joint component. Let's just assume that for this illustration, Dr. Lieberman's hospital in Texas is fairly close to the national average that you see on the screen at about $41,409 for DRG 457. But that varies all over the country, and it could vary significantly by hospital. So you may want to check with us with regard to what your hospital would be projected to receive. We have some contact info at the end that we'll share tonight. In addition, for Medicare cases, we want to review the hospital's potential add-on payment from Medicare of up to $9,828, since this patient was, as Dr. Lieberman said, Medicare eligible. In case two, by contrast, on the bottom half of the screen, that's an SI joint fusion that's been reported, and he put that on his op note. And so the open SI joint fusion code, CPT 27280, is therefore appropriate. After reporting the bilateral work, and assuming this is the second listed code following that primary lumbar fusion procedure, again, not on this screen, let's say that was $1,700 or $1,800 from Medicare. Then the surgeon's fee for the SI component is actually quite a bit more than the pelvic fixation in case one. In this case, we can estimate that the SI component is actually paid at $1,049 by Medicare if it's the second reported procedure. The facility side is unaffected as it was in case one, as it's sort of the lumbar fusion procedure that drives the DRG, barring some additional comorbidities that may get picked up as a result of including the pelvis. But assuming no added comorbidities, once you take into account the pelvis, then the same DRG for that spinal fusion for curvature applies, as does the potential of up to $9,828 incremental reimbursement to the hospital for Medicare. And I want to define this add-on reimbursement that we keep referring to. So this is the CMS New Technology Add-on Payment, or NTAP program. It's a Medicare program that's been around since the early 2000s. It's intended to encourage innovation among the industry, as well as to allow Medicare beneficiaries early access to innovative technology. To be eligible for NTAP, the technology must be considered new by CMS NTAP program standards. Importantly, it needs to be considered a substantial clinical improvement over available therapies. And assuming the technology is also costly enough such that it's not yet reflected in the current DRG payments for the applicable procedure, then an NTAP will trigger to compensate hospitals for that added cost. It's only for Medicare patients, only for inpatient stays at the hospital. I'll define a little bit better which kind of Medicare patients I mean in a moment. But I wanted to touch on a topic that we hear a lot, which is how is it paid mechanically? How do we move forward ahead? I want to get into all that, but before I do, let me just make sure we have a full understanding of what NTAP is. Simply put, it's a way for hospitals to be compensated by Medicare for adopting new innovative technology and giving it to Medicare patients early. It provides incremental payment for cost overages that are identified in the case through charges and then through normal coding and billing practices at the hospital. And CMS tries to make it a seamless, easy mechanism. Just to be clear, it's effective October 1st, so we're a little early this evening telling you about it September 20th, but it won't be effective for cases until October 1st of this year. And it lasts for up to 3 years, so we expect it may last until September 30th of 2025. So I mentioned the mechanism of NTAP and how CMS tries to make it simple for hospitals. And they do this by tapping into routine coding and billing practices. So on the next slide, I'll show you all of the new unique ICD-10 PCS hospital procedure codes that Medicare assigned to Granite cases. Once the hospital reports one of these special codes on the claim form that they usually use to submit for reimbursement, the analysis for add-on payment is triggered. And at that point, the Medicare Administrative Contractor, or MAC, calculates the NTAP based on the costs reported for the case relative to the hospital's normal DRG payment. And if the costs exceed the payment, at least some NTAP is then released. The actual payment is part of the operating portion of payment for new technology, along with the reimbursement dispersed by Medicare to the hospital. So here are Granite's 8 unique hospital procedure codes. They're designed to tell Medicare that a Granite case was performed and that an NTAP analysis is now required. As you can see, the codes span uses of both fixation and fusion, as well as both percutaneous or MIS and open procedure types. So there are 8 codes in total. You only need to report one of them to trigger the NTAP calculation. Most importantly, they're for Granite only, not for any other technology. So these are a new technology section of codes. For any non-Granite uses, use the prior existing ICD-10 codes that predated these. And here on the screen are the possible DRGs associated with a Granite case. These would be the same DRGs the hospital would receive payment under, whether it was a fusion for deformity or a 360 fusion, otherwise with or without Granite. The inclusion of Granite in the case does not by itself change the DRG, though the severity of the patient's SI condition may affect that ultimate determination of which medical severity you go to within the DRGs. But as I mentioned, that may or may not drive a different DRG. Also, I should note that there's a lot of discussion about NTAP in this presentation. The numbers on the screen right now are all pre-NTAP, so no NTAP is included in them. I wanted to talk about this fixation versus fixation with fusion that Dr. Lieberman presented in his 2 cases tonight. Both could be appropriate uses of Granite per its FDA labeling. The NTAP, the good news is, will apply regardless of whether Granite is used in that fixation configuration, meaning 1 implant per side, perhaps, with no other fusion promoting devices, or NTAP will apply if it's used in the fusion configuration where, let's say, stacked Granite is used, as in Dr. Lieberman's 2nd case, or if it's Granite being used along with another fusion promoting device. So once the procedure coding is appropriately reported by the hospital on the claim form for reimbursement, then the NTAP will apply. Of course, it may impact the charges that you ultimately submit to Medicare, which, as we'll see as the presentation goes on, drives how much add-on payment will be received. So we get a lot of questions about the appropriate reporting by the physician in these cases as well. some of this is important to the hospital's coding as well, because some of it relies on what's in the op report that may go over to the hospital teams, hospital's billing teams. So I wanted to just touch on it for a second. And I wanted to firstly give a couple of answers to two frequently asked questions that we get. We wanted to talk through, reporting of either the minimally invasive SI joint fusion code 27279 or the open SI joint fusion code 27280. Both may be appropriate to describe the use of Granite, assuming the surgeon feels that the operative steps that he or she took, including any instrumentation that they used, describe and support an arthrodesis. So I wanted to just clarify that. If a second fusion device was not used, such as a second Granite implant or another of our fusion promoting implants, then, as I said, the NTAP will still apply, but the physician should consider what our FDA labeling says about the requirements for fusion versus fixation. We'd be happy to provide that information to them. So earlier, I teased a little bit about Dr. Lieberman's two cases and how they might get coded and paid. Here's where we wanted to show you our work on the math. And this is the CPT coding and payment scenarios that are applicable to either the fixation only use of Granite or where fusion was reported with Granite in that second case. So CPT 22848 shows the use of non-fusion pelvic instrumentation like S2AI screws or even iliac bolts they're used to describe today. And that allows, as I said, for $367 unadjusted from Medicare, one instance per case. As I said, maybe commercial payers might allow you two instances and pay you that, but I've seen more rejections than I have payments on a second use of the 22848 code, just our experience. And this includes even a bilateral case as well, one instance, even a bilateral case. And so we'd encourage you to check, of course, with the commercial payers, even ask your MAC, couldn't hurt to just ask them, but that's what we've been experiencing. When fusion is reported, by contrast, CPT 27280, for instance, if it were an open procedure, as many are, by that point, these are longer construct fusions, that code may be used to describe the SI joint fusion, and it would include the instrumentation you would have reported under 22848. But we interpret 27280 to include all that instrumentation. So in other words, 27280 bundles in all of that instrumentation. As you can see from the math on the screen, though, it really doesn't matter. It's more than a wash. It's actually a higher reimbursement, appropriately so, because there's more work that's being reported to perform the arthrodesis. And so even if that SI joint fusion component is a second or third listed procedure, it still theoretically is a higher surgeon reimbursement than the 22848 code alone for fixation only. So, the reason for this is because of a rule called the multiple procedure reduction rule that Medicare and virtually all commercial payers apply to the second or third listed procedure code. When you have a primary procedure, in this case, the lumbar fusion, above the SI joint, then that would be paid at 100%. And the scenario I gave is, for instance, a $1,700 or $1,800 payment at 100% of that first code. The SI component is now the second or third procedure down in terms of what's being done in the operating room that day. And so the multiple procedure reduction rule by Medicare requires that the second code being submitted is reduced by 50%, presuming that a lot of the work involved in getting to that part of the anatomy has already been done above. If it's the third listed code, it may be paid as little as 25% of its original rate from the same rule. So encourage you, again, check with the payers if you have questions about this, but pretty standard for multiple procedure scenarios. So just wanted to clarify that. And another FAQ that we get a lot is which patients are actually eligible for NTAP. You say it's for Medicare. I think I get that, but there's a lot of Medicare out there. So firstly, to clarify, this is a Medicare-only program, so we don't anticipate any commercial payers would offer something like an NTAP, though they typically tend to pay higher, we hope. But as we've learned, there are a lot of Medicare-age patients who may have a supplement plan from a commercial carrier, so you're seeing two different payers. So we wanted to clarify that these are all okay. This is known as a supplement plan or a Medigap insurance plan, and even Medicaid can be a secondary plan for a Medicare patient sometimes. So this NTAP would apply to all of those types of patients. However, if a Medicare patient has a managed Medicare plan, often called, Medicare Advantage, Managed Medicare, or Part C, or has otherwise signed up with an HMO, those cases would not apply for NTAP, as they are not fee-for-service Medicare. They're just paid differently. So we think that, by and large, these are the minority of cases, and depending on your specific area of the country and what's popular there in terms of plans for Medicare age patients, we think NTAP would apply to a good proportion of your panel of patients. So I wanted to round out the evening with some examples, and I want to provide you 3 different examples of the NTAP at play for 3 different fictitious hospitals performing 3 different kinds of Granite cases, or using Granite in 3 different kinds of cases. So hospital A is going to be what we call the full NTAP scenario. For example, that hospital charges $225,000 for the entire spinal fusion case, including charges for Granite. And because of its cost to charge ratio of 29% or 0.29 on file with Medicare, the hospital's charges get reported to Medicare as $65,250 of costs. So taking down charges to costs. And if that DRG payment applicable to hospital A from Medicare, let's say, is only $46,000 for this curvature, spinal fusion DRG, then you have a difference of $19,250 between the reported costs and then the local payment from Medicare. And the NTAP program intends to cover 65% of that difference, up to a cap of $9,828 that they have on file from our application for add-on payment for Granite. So a lot of this stuff is locked in, but as you can see, there are plenty of variables at the local facility level, as well as on a case-by-case basis too. So in this case, to finish out the math, the difference of $19,250, even at just 65% of that difference, is still greater than the cap for Granite of $9,828. And so the hospital may anticipate receiving the full NTAP amount on its new technology, line item in the reimbursement for that case, in addition to the normal DRG payment. So that was the full NTAP scenario I wanted to make sure we ran through. And then here is hospital B. Again, different hospital, different set of circumstances for the case. And for example, this hospital charges $200,000 for a spinal fusion that uses Granite. In this case, the hospital's cost to charge ratio is 25% or 0.25. And the hospital's charges get reported, therefore, as $50,000 of costs. That makes a difference here of just $6,000 between the costs that were reported and then the applicable DRG payment, which we're seeing here is $44,000. So less difference between costs and payment, right? And the NTAP, again, will allow up to 65% of that difference. In this case, that's $3,900 below that cap, and therefore the hospital can expect $3,900 of add-on payment incremental to its DRG payment. And the third scenario is no NTAP. And this is an otherwise NTAP eligible case. This was a Medicare case, let's say. It was fee-for-service Medicare. The NTAP calculation was performed by the MAC. But in this example, the hospital charges $180,000 for the spine fusion with Granite. The cost to charge ratio is 21% or 0.21%. So those charges get reported as just $37,800 of cost. And by the time you do that, your payment of $42,000 is actually adequate, even with the inclusion of the Granite charges that you've reported. So the hospital won't receive NTAP for that case. Rather, the typical DRG payment would apply. So we wanted to break down those 3 scenarios. Those 3 scenarios do exist on our coding guide for the Granite device and the NTAP. And we encourage your questions directly with us now in the chat feature, or we can follow up and address them with you later. But regardless, the more important thing is we just wanted to make a connection with you. And if you have more questions, please reach out to your SI Bone representative or to us on the reimbursement team directly. And we'd love to provide you answers. So with that, wanted to just kind of check in on a couple of more frequently asked questions that we get. And again, feel free to use the chat. The other question that we tend to get a lot is, would a case be eligible for NTAP that reports just one code, one of the Granite codes? And the answer is yes. Of course, that might impact the charges for that new technology. And we've seen, hospitals, all over the board with charges for new technology, especially before some of the sort of charge masters get calculated or calibrated rather. And so one instance of a Granite code may lead to different charges than, let's say, 4 instances of a reported Granite code. But regardless, that is eligible for NTAP and goes through the calculation nonetheless. And then the other question that we get a lot is, what happens if it's after October 1st and we accidentally submitted a claim to Medicare without the Granite code, without the unique ICD-10 PCS code? Can we correct it or fix it? And the answer is yes. You can submit a corrected claim through the normal, corrected claim pathways, and then include the unique code on there, and then that should trigger the NTAP calculation. So one other question came in, and want to address it because it's a good one. So Jared asks, what establishes the charges for each hospital example? How did we come up with them? And the answer is we made them up. What the hospitals have tended to charge historically for these DRGs is public information. It's also information well known to each institution. And what my suspicion is, having worked with hospitals around the country on various NTAPs from different technologies, different companies in my career, has been that the charges for new technology may be different than for commodity products. Not always the case. And certainly those, representing hospitals or health systems on the line can probably address that better, but that's been my experience. So sometimes it's, the same charge, factor as a tongue depressor. Sometimes it's 2 times that, 3 times that, 4 times that. Really, it's all over the map. But regardless, all of those charges come together with the usual and customary charges for that type of DRG spinal fusion case, and together they create the report to Medicare that goes into the analysis of charges that turn into cost. And so, whether hospitals alter that strategy or change that strategy, I haven't seen too much of that. I've seen hospitals already have their strategy in mind for these kinds of things. So appreciate the questions. Well, we want to be sensitive to your time and really appreciate everyone joining us. As always, please reach out to us if there's anything that we can follow up about with you. And really, thank you very much for joining us.